I think that most women's problems, lady things, they always seem mysterious to everybody, including the person who has it. It's like, ooh, what is that? Like, we should say, what is PCOS? Like, what does the P stand for? What does the C, like, what is it?
Polycystic
Ovary.
Ovarian Syndrome.
Yeah.
PCOS.
Why is it important to understand the metabolic ties to PCOS, Dr. Cooper?
Oh, I think it's just so important because it gives you hope that if you can figure out those metabolic ties, and those can be a target of treatment and focus, then you're talking about taking something that has this image of being a permanent condition, but making it reversible.
So there's hope.
Yes.
Isn't that great?
Mm-hmm.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so good to see you both.
Hello.
Here, hi.
All right, on the show this week, we are taking a look at the metabolic connection to PCOS. And you've probably heard the term PCOS being thrown around. And it's a very common medical condition, but I have to be honest with both of you. I have absolutely no idea what it is. I know it's serious. It can be serious. And I know it affects a lot of people's lives. So let's jump in, Dr. Cooper. Break down, what is PCOS?
Well, PCOS is a very common condition that is involved in infertility commonly in women. And PCOS stands for Polycystic Ovarian Syndrome. And I've always had an issue with the name of it because it implies that it's a disease or something of the ovaries, when actually the ovaries are sort of an innocent bystander in this, and they are just reacting to imbalances within the neuroendocrine metabolic system, and it's affecting the ovaries. And so when we think of PCOS, Polycystic Ovarian Syndrome, it sounds like it's something wrong with your ovaries that's causing the issue. But in fact, it's a bigger, deeper problem with the metabolic system and some feedback loops and chemistry there that affects the ovaries. And the cystic part of the name is also a little bit incorrect because this is not to be confused with ovarian cysts. People have ovarian cysts, and those can be very painful. They can be just enlarged areas, cystic areas in the ovaries that sometimes can actually rupture, and that can be associated with a lot of pain, and they can be quite large. But what we're talking about with polycystic ovarian syndrome are these tiny, tiny little they call them follicular cysts, when they're not really cysts. They're just
like follicles?
Yes, exactly. They're follicles within the ovaries that need to mature, and then they develop into a mature follicle that when it ruptures and releases, that's ovulation, basically. But with polycystic ovarian syndrome, due to a lot of imbalances that occur, the follicles don't mature, and often there isn't ovulation. So the menstrual cycles can be what's called anovulatory, where you're not really ovulating, but your ovaries can be filled with these immature follicles. And so those are what people refer to as these cysts, and they're tiny, tiny, tiny. I've had a lot of patients who were told they had ovarian cysts that were larger, and they immediately thought, I must have polycystic ovary syndrome, and it's just not the same thing.
And the reason that this is so important and so serious is that it can really disrupt people's ability to have children, right?
Definitely. It really can, because one of the criteria for the diagnosis is that someone would have what's called oligomenorrhea. What that means is
That's a biggie.
we should all learn Latin, I think.
Whoa.
I'm sure it's pretty.
Oligo. It's like
Oligo.
Lego, but not.
Oligo, I think, just means like few periods, like far apart. They're irregular, and there are long periods of time between the cycles. So these are women. Yeah.
Does it also like? I think I have some friends who also had like really painful periods too. Does that come in that, or is that another? No.
No, not necessarily. Painful periods can be due to a lot of different things, but
Maybe it was in conjunction.
I mean, I guess there could be painful. These can be abnormally heavy periods when they do
Maybe.
come.
Yeah.
But there's often, the normal cycle length is about 28 days, plus or minus. With PCOS, often people will go 35, 45, 50 days between their menstrual cycles. And so that's one of the criteria to make the diagnosis is irregular menses that are oligomenorrheic, that are gaps far between. And the other criteria, that's the strong criteria, is either having high, what are called androgen levels in women. Androgens are hormones we associate with men, the male hormones like testosterone. There's another one called DHEA sulfate. Elevated levels of these testosterone levels or androgens, or the physical signs of elevated androgens is also an acceptable criteria. So that would be for women. And, with this, you have to think about ethnicity too, but it would be women with something called hirsutism, which is a lot of facial hair growth, abdominal hair, abnormal amounts of hair growth. But again, that can be due to ethnic differences too. So that's not definite criteria. And acne is another manifestation of high androgens. So high androgens in women can lead to abnormal hair growth, face or abdomen, usually like the lower chin area usually, or acne. So if somebody presents with these gaps in their menstrual cycle and has signs of high androgen levels or has blood androgen levels that are high, that is now sufficient to make the diagnosis, which to me seems like really not very much to put that diagnosis on someone. But because the thought is that making everybody do a scan to look into their ovaries is not that realistic because of the expense. And also some people, ideally you would do what's called a vaginal ultrasound instead of just an abdominal. And those are a little bit invasive, and some people don't want to have those done, or maybe they're too young to consider doing that type of a test. And so it's acceptable not to do the scan to identify the follicles being overly abundant. And so that's a very kind of basic diagnostic criteria. It used to be that it was expanded so that there also had to be an elevation of luteinizing hormone compared to follicle stimulating hormone. So those are two hormones that we call them the brain reproductive signals because they're produced by the pituitary, and those are the hormones that tell the ovaries to start that process of maturing the follicles and when to ovulate and all of that. And there can be imbalances there that are seen with this condition, PCOS.
I feel like in much the same way that we identify and define metabolic syndrome, which is a collection of conditions, PCOS seems to be a hormonal disorder that is defined by a collection of conditions, right? So, hormonal imbalances, ovarian dysfunction, polycystic ovaries, metabolic issues, fertility challenges, all that stuff is sort of the defining factor. And I love how, Dr. Cooper, you said the ovaries are sort of this innocent bystander to this whole thing, that they just are impacted by this. I'm guessing a lot of people listening, Dr. Cooper, might wonder, how do I know that I have PCOS? And at what age should I start being concerned about it?
It would be a little bit hard to know on your own. In fact, even you could meet the diagnostic criteria that I just said, those two things. And there could be a lot more going on than just what you would think of when you imagine PCOS. But I think looking at the menstrual cycle, and if there's irregularity there, like longer cycles typically would be the case. When I say longer cycles, I mean from the first day of your period to the next first day of your next period. More than 28 days, just extending from that. That would be one indicator. And infertility, there would be a workup done to make sure or to find out if it's related to PCOS. And also that abnormal acne and hair growth in the facial area or definitely the abdominal area for women. So those would be some signs of it. But again, it's sort of, because I feel like it's really an innocent bystander, the whole ovary situation. I think that it's important to look at the entire metabolic system if you have irregular periods, because we talked in past episodes about how the metabolic system affects fertility. And we weren't even talking about PCOS. We were talking about numerous other ways that the metabolic system can affect fertility. And so there's so many other reasons why your period could be irregular that are metabolic, and you still may not meet the full criteria for PCOS. It's not necessarily PCOS. It could be something else. And because when we think about the menstrual cycle, think about how it works. The hypothalamus sends what's called releasing hormones to the pituitary, and in response, the pituitary sends stimulating hormones to the ovaries. And then that's how the cycle happens. If you've got metabolic dysfunction, so many things can interfere with the hypothalamic signals that are even starting out with those releasing hormones. And then other things can interfere with the pituitary stimulating hormones. And other things can interfere with even how your ovaries respond to the signals. And so when I say other things, I'm talking about the things we talk about a lot on this podcast, which are the orexogens, which are the hunger signals. So we're talking about ghrelin, agouti-related peptide, neuropeptide Y. Those elements interfere almost everywhere along that cycle, in the hypothalamus, the pituitary, and the ovaries. And so there can be an overlay of that, and that can also accentuate some of the features of this PCOS, or it can create different infertility problems. And similarly, our endocrine system is controlled a lot by our nutritional security signals. So not just the famine signals, but also what about the signals that say that we're not in a famine, such as our leptin levels and our nutritional status. So we look at that, and if that's weak, that also influences the hypothalamus signals, the pituitary signals, and how our ovary responds to that. So that's what I mean by it's a much bigger picture than just saying that a woman's androgen levels are elevated and they may have these follicles in their ovaries or irregular periods. Because, all along the way, there are these metabolic influencers that could contribute to that dysfunction and other problems as well.
I think that it's just something that you don't always think that your brain and your nutritional signals have anything to do with your lady parts. You just never think that. You just think, oh, this is my lady hormones. That's one section. And you never think how everything connects. You just don't think that. You think we always think everything is segmented because, we go to specialists all the time. Everything is a specialist. And it's one of my problems with how we think of medicine. You go to a gastroenterologist, you go to a heart doctor, you go to a lung specialist. And when they don't all work together, you sometimes miss things in your treatment. And it's sort of like how your body works is all together. It's a functioning machine. Sometimes you forget about that, that like your brain talks to your metabolic system. Your metabolic system talks to your reproductive system. And you forget about that. And Dr. Cooper always, what's great about working with Dr. Cooper that I've found for me is that she looks at my whole system and it's like, oh, that's why that's all messed up. Because that didn't talk to that. Oh, I got to fix that over there because that's not going to hook up. It's like that old song, the elbows connected to the... It's that. It's that. And that's
It
what
is.
this PCOS is. And I think for so many women, especially who I know, I mean, I hate to bash some of their doctors, but the doctors didn't look. The doctors didn't see that there was like a missing part that was connected to the connected to the connected.
You said it so well, Andrea. You'd be a great, a great doctor.
Oh
Yeah.
no. Oh
Yeah.
no.
I know
I
you don't
didn't
want to
take
do that.
chemistry. I would blow up the room.
If Andrea was a doctor, the accountants would come to her and say, "You saw 3 patients yesterday.
Oh my
What happened?"
God. I know. And you blew up the lab.
Well,
And you didn't weigh out anything. You gave everybody way too much drug because I can't count.
but
Oh my
that's
gosh.
that I have to say, it's so funny because I guess I don't know. I think that becoming a doctor or something's in your genes a little bit. But
I think it is. I would
Yeah.
not be good.
well, I remember, when I started kindergarten. I know this sounds really
Right.
crazy.
We knew
This
you
is
would
great.
be a
We love
doctor.
tangents. Go.
We knew you
Well-
would be a doctor.
Well, the thing is, I always was I thought that once I started kindergarten, what I was going to learn was how the body works. I literally thought that's that was my expectation that I'd
So
walk.
you're like, "What the heck?"
Yeah. I thought I'm going to walk into kindergarten and we're going to start learning how our bodies work. And I don't know why I had that preconception, but I thought that's definitely got to be what it's about. It turned out it wasn't.
No, they did blocks.
But then, so I went to med
Coloring.
school. When I went to med school, I honestly, you don't realize when you're in med school how segmented the medical curriculum is until because you figure you're learning this way because you don't know anything. So you're just learning the basics and you're learning your foundation. And actually, in learning the foundation, it was a little bit more connected because biochemistry, physiology, is a little more, when you're doing the basic sciences, seemed a little more like the big picture. But then when you start in med school and through the training process, it is really strange how segmented it is, as you're describing, Andrea.
Yeah.
And then when you get out into practice, you realize like you're trying to make referrals to these doctors and they're like, say it's an ENT. Oh, we only do ears, or we only do nose, we only do
Right. We only do ears,
Yeah.
nose, throat. Oh, we
Right.
don't do eyes.
Or if it's like an endocrinologist, we only look at thyroid problems, we only work on diabetes, we only work on very, very specialized, highly specialized into these key areas. And the same thing's true for researchers too in science a lot of times. So what we're really lacking is that systems approach to it, because when you look at anything else in our world, there's a systems model of how everything's interconnected, like our transportation system, our public health, everything looks at it that way. But in the medical field, we're lacking that. And that's where I think some of my fascination with the neuroendocrine system came about, is because I see that as kind of the glue that connects everything. And once you start focusing on that and try to keep your eye on that and look at things through that lens, then you are looking with this more of a systems kind of model. But that's just a tangent. But I'm glad that you
I
mentioned
think
that,
it's
Andrea.
interesting, though, that Dr. Cooper, you've mentioned other examples of when the brain feels that your body is under duress or under a threat, it will shut down the reproductive system because it doesn't want to bring a baby into a threatened environment, right? Because you've talked about how restricting calories to a certain point can stop ovulation. So it's interesting when you look at this PCOS that when the brain senses that something's off, then it can really whack things out.
Right. It's so funny how the brain plays such a big part in so many things that we don't know the brain is a part of. And you forget about that.
Well, and it's the brain and it's what we call the peripheral system too, which is, the end targets of the brain that are affected. Because a good example would be in infertility, if your famine signals are real high, one thing that could happen, and if you had low security signals, high famine signals, one thing that could happen is that your gonadotropin levels from your...
The what?
Sorry. One thing that could happen
You're talking to two non-doctors.
sorry.
We don't know. We don't
Is
know.
that-
That just sounds like an animal. A gonadotropin is
the brain
is in
signaling.
the forest.
Let's go back to what could happen is the brain signals, the brain reproductive signals could be suppressed. So they could say, no, don't ovulate. So they could fail to stimulate the ovaries or the testicles, really. We're talking about PCOS, but can affect men too, similarly. But they could fail to stimulate the ovaries to go through that ovulation cycle. But there's another way. If you had the same imbalance in another person, what could happen is it would go through the brain signals. The brain would still be signaling to the ovaries to, hey, you got to ovulate. But these interfering famine signals and the weak leptin would prohibit the ovaries from responding to those signals. So you would have the signals coming from the brain, but the ovary still won't respond because in the circulation, the environment says you're starving. So the brain's deciding, I'm comfortable with you ovulating, but the ovaries are saying, nope, I get these signals here that say it's not safe. And that resembles PCOS a little bit because with PCOS, typically the brain signals are kind of yelling at the ovaries and the ovaries are not responding. And so when we see that metabolically, we understand there's a feedback loop there. So if the ovaries are not responding and the follicles aren't developing, the ovaries are starting to produce like testosterone in response. And that testosterone has some further inhibitory effects on the whole thing. And so with PCOS explanations, a lot of times doctors stop at that and say, well, it's because of the testosterone. But when you think about it, those hunger signals that are high and the security signals that are low are also causing the ovaries to not respond to that signal from the brain. So that's why it ends up, instead of developing the follicle, the testosterone starts to increase. I'm just trying to say, I don't mean to get it too technical or putting out too many ideas with this, but when you start looking at it from that system standpoint and you start looking at how everything's connected, the best strategy would be, well, let's start by getting these famine signals down and the security signals up, because that's something we can do. And I would say in my own practice, 9 times out of 10, once you do that, you don't have any indication of PCOS anymore. It resolves. And so
Right.
it
It
just
can
goes
go
away.
away.
So I think that, again, it's stepping back from that microscopic segmented view of the ovaries and looking back at the bigger picture. And it is kind of simple. Metabolically, it sounds complicated when we start talking about all the players in the pathway, but the gist of it, the overall, is that there's really, when you think of, say, if it's PCOS or if it's obesity, most often it's caused by an imbalance of security signals that say we're not starving versus famine signals that say we are in a famine. There's an imbalance there. And
I
so,
think
yeah.
it's easy. You're saying it's easy. That's because you are somebody who is skilled in knowing where to look. You have a very good you have a history of knowing where to look. But I think for a lot of doctors or clinicians or whatever you're going to, they don't have a history of knowing where to look. And I think that makes it very different for some people when they go to their, help me person. I think like sometimes people are like, I'm having trouble conceiving, and they're like, oh, well, maybe you should lose weight. You're too, maybe that's part of the problem. Then they start starving themselves, and then they look and they're like, oh, well, now you're anorexic. And I think sometimes that's when they find the problems sometimes, because they're like, oh, now we're seeing, when they do the test for that is sometimes when I think some people I know have found the issue that it was PCOS and not the eating problem.
Yeah, I was thinking the exact same thing, Andrea, that Dr. Cooper, you're describing how you approach PCOS, but is that how traditional medical doctors look at it and diagnose it?
Well, they're starting to, they're not really looking at maybe those specifics, but the endpoint is starting to get in alignment because for many, many years, one of the treatments of PCOS is metformin. And that's because a lot of women with PCOS have insulin levels that are elevated. And in fact, insulin, because it's all part of the feedback loop, and if you have too much insulin, it's also driving negative signals through that metabolic pathway that could interfere definitely with the ovary response to the brain signals. And metformin is known to improve insulin resistance. And so metformin has for a long time been one of the main treatments for PCOS. And that's for people who don't have diabetes and don't have even prediabetes. And so metformin is one treatment. And another thing that is done sometimes is spironolactone. You may have heard of that drug, spironolactone, but it is used to reduce the androgen levels in the skin to improve like acne and the hair growth, the physical symptoms. And it does calm down the androgen levels a little bit. And then another thing that is a standard treatment that we don't find the need for doing this standard treatment typically because we're focusing, as I said, more on that metabolic system. But to calm down the testosterone production to try to improve the situation, often women are put on birth control. One of the problems with the birth control is most forms of birth control actually kind of make the problem worse because they create imbalances in your metabolic system that then feed into more difficulty with interference with the reproductive cycle. So there are very specific, especially when it comes to the progesterone component, there's specific types that are better and more like friendly if you have PCOS than others. But that's the standard treatment would be a combined birth control pill, spironolactone, and metformin. That's the standard. In our practice, because we're focused a lot on the metabolism and we kind of put a lot of faith in the metabolism, we might use spironolactone if someone has really annoying acne or facial hair growth. We may use spironolactone to help reduce that in the skin. And we may use metformin if we have like high insulin levels, because we do that regardless of PCOS. And then we are going to start targeting that metabolic system. So eating regularly, don't be on a diet, get your sleep, get checked for sleep apnea if necessary, fuel your exercise, and then start looking deeper. Are you a candidate for any pharmacologic treatment that's targeting metabolism? And so this is where now a lot of doctors who treat PCOS are noticing that some of the medicines for metabolism improve PCOS and improve fertility. So they finally have made that shift. And so now that doesn't sound crazy to them, you know. But again, they're maybe not looking at all the mechanisms involved, and no one really knows, too. I mean, the science isn't like hard science. We're looking at, from my perspective, I'm looking at mostly clinical practice data and textbook data as well. You know, you have to dig deep for some of these little small bits of information. You have to get textbooks that cost like $200 for a half-inch textbook, and then search through there that are very specific to the actions of some of these orexogens and stuff to find that, yes, indeed, they do influence these end targets, so they are involved. But I think with most doctors' perspective, they're noticing, well, what's useful? And they may start using GLP-1 meds and along with their metformin and their spironolactone. And, you know, they may not rely as much on the birth control as time goes on, and they may be shifting more to this metabolic model. So it's interesting. I think ultimately the thing that I see that's not good with the standard PCOS treatment is what Andrea described, is being told to kind of go on a diet or exercise without fueling it, without attention to how the person's fueling, and to, quote, lose weight. Because it's true, there is an increased diagnosis of PCOS with increased body weight. So people with higher body weight are more commonly diagnosed with PCOS, although it can be diagnosed in people at normal weight or even underweight people. But so the advice is often you should lose weight. And then,
Yeah.
And then
you
it
know,
goes the opposite.
yeah, it implies a diet, which then goes the opposite.
Isn't that crazy? And I think there's also a higher incidence of fatty liver among PCOS patients. But again, I'm not a doctor, but I'm learning from you, Dr. Cooper, that the insulin problems probably have more to do with the fat accumulation. Would that be fair to say?
Yes, I mean the insulin metabolically, all of those orexigens and the high insulin can lead to fatty liver, and then also sex hormone binding globulin is involved.
Okay, that's like so graduate level.
Hey, our eyes just glazed over.
Well, the elevated testosterone levels in women, that sex hormone binding globulin binds testosterone. And so in women with PCOS, it's been seen that their sex hormone binding globulin levels are low, so that their testosterone has more action because it's not bound, so it's free to have an effect more. And so that dynamic also has been shown to be a trigger of fatty liver disease. And then the fatty liver kind of perpetuates the problem with the sex hormone binding globulin. So again, in the body, there's so many feedback loops. So it's hard to tell, well, how did it start in the first place? Because once something's established, it kind of creates a vicious perpetuating cycle in a lot of areas that kind of amplifies the problem. But there is an association there. And so not every single person with these PCOS indicators is going to have fatty liver. But again, it's true. If you then put them on birth control, that's going to mess up the metabolism, then you're contributing to fatty liver risk. Or if you're going on a diet and doing the weight cycling, you're contributing to fatty liver risk. You're increasing it. So it really doesn't make sense.
There you go.
I'd love to know, just finally, Dr. Cooper, as we wrap up, I'm sure there are a lot of people listening who have been struggling with PCOS.
Yeah.
Just struggling to just get a basic diagnosis and maybe struggling how to treat it. What advice would you give them if they're in the middle of that struggle?
I would try to, again, focus on how do you have the healthiest metabolism possible, and see then what happens with the PCOS indicators. Definitely look for the baseline measurements of your androgen levels, your brain reproductive signals, which are called LH, FSH, your estradiol, and look at those figures, but then focusing on the metabolic system, fueling regularly, all the food groups throughout the day, getting adequate sleep is essential, and making sure if you do have any symptoms of sleep apnea, get checked for that, because that contributes to unhealthy metabolic changes, and fuel the exercise. But then, once you have that workup, talk to your provider. Well, what were my insulin levels? Should I be on something like metformin, or do I need something more than that to strengthen my metabolism? Do I need potentially other medications such as GLP-1 mimetics or other medications that might target whatever your provider finds is going on metabolically? So I think, but what I wouldn't do is give up hope. I wouldn't join a support group, because, and label yourself too much as this, I'm a PCOS patient, because I feel like there's so much despair around PCOS when it actually doesn't have to be a long-term condition. There's so much hope to get that to reverse. And so I know that some of that desperation comes from the infertility piece of it and how it affects our fertility, because it's true, women who have this going on are less responsive to fertility treatments too. And so it's really important to calm down the dysfunction in order to be successful in fertility, even when you're doing the fertility treatments. And so I think, but have hope. And so try to figure out how to improve the metabolic system, and don't go on a diet. Don't try to intentionally lose 20, 30 pounds by depriving yourself. That won't probably work. So that's all I'm saying.
That's good advice. Andrea, any final thoughts from you?
I would just want to say, if you have PCOS or you've been told you have PCOS, just know that there's hope for reversing it, that you're not going to be some kind of victim for your whole life, because that victim head is just never successful. You got find somebody who will help you, and know that it's connected to your metabolism, not necessarily just like a fatal diagnosis.
Yeah. Well, this has been super enlightening. Really appreciate the conversation today. And if you have any questions for Dr. Cooper, info@diabesityiinstitute.org is the email address. And if you have a show idea or any questions, that's a great way to connect with all of us. All right. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.